Hello.
Good afternoon all. So our next case is 75-year-old female with complaint of left shoulder pain and restricted movement since 5 months. No history of significant trauma in recent history. On examination, abduction and forward flexion range is 0 to 60 with weak external rotation and tender biceps. MRI image is suggestive of complete tear of supraspinatus tendon with significant retraction. And on the sagittal MRI showing the grade 2 gluteal atrophy confirmed by the MRI reporting. Moving on to the live surgery.
So we discussed about this case. I had a look at that patient yesterday. She's not 75. She's a 62-year-old lady who's had a fall about 6 months back.
Okay.
And in the MRI, as rightly said, it's a Pate grade stage 2, or I would say Pate stage 3, where there's a supraspinatus and an infraspinatus retraction up to the glenohumeral joint or a little beyond that. I would say supraspinatus was near the glenoid. Now, there is a significant amount of fatty infiltration which was seen on the MRI. That's probably a grade 2 of fatty infiltration. And interestingly, when I did see the sagittal films, I could also see it's a kind of a Collins type 3 or type C kind of a lesion, where is the superior part of the subscapularis I feel, then there's the supraspinatus and infraspinatus tear. Now, I do all my shoulder work of cuff in a sitting position. So we had a sitting position here, standard posterior portal and then a standard anterior portal. I established these two portals and then went ahead, released a little bit of the rotator interval because she was a little stiff to expose the subscap. Now subscap was fine, not too bad, adequate tension, but the attachments were pretty much all right. If you see that, this is the subscapularis, and on internal and external rotation and even on stress, the subscap integrity was fine. Of course, a little bit of degeneration expected with the age. I then went ahead and visualized the cuff. Of course, this was the biceps tendon. Am I audible?
Yeah.
This was the
slightly
biceps tendon.
Faint. You need to be slightly louder.
Yeah, this was the biceps tendon.
Okay.
Biceps tendon subluxed. A little bit of a degeneration of the biceps tendon there. That was the rotator cuff, and I went ahead subacromial, started debriding the subacromial tissues. A little bit of a bursa there, but yeah. So I usually use 5 portals for my cuff work. I use standard posture, posterolateral, anterolateral, anterior, and sometimes mid-lateral as well. So I usually switch, at this point I switch my viewing portal into the posterolateral portal, and that gives me a better access, 360 degrees view of my rotator cuff, and my appreciation of my infraspinatus and supraspinatus is much better with this posterolateral portal. As you see here, my vision becomes a little better. I would like to clear off all these curtains. I would like to expose my supra as well as my infra. I've used a 3.5 shaver here.
Chirag sir, you need to be slightly louder. Your voice is a little faint. Yeah.
Anshu,
yeah.
I'm weak. I'm not strong like you. So so here look at this. That's the infraspinatus, the tissue over the infraspinatus. The bursa, I'm clearing it off. As I go here, the tear looks to be exposed. The biceps tendon lying there, not a great biceps tendon tissue. The supra and infra retracted back up to the glenoid almost. And here you are, a bald head. There's hardly any kind of attachment there. Little bit of a tissue is lying down in the footprint. I would like to clear off that footprint. I would also like to clear off my subdeltoid bursa. And once I've done that, I would just medialize my repair a little bit. This kind of retracted tear, I would like to extend by 1 or 2 millimeters my footprint medially. So I go on debriding that. I usually use a curette to debride, just to get some punctate bleeding, so that there's no excess of decortication of my bone. because otherwise the anchor would pull out. I use my 3.5 shaver. As you see here, I'm getting a little bit of a bleeding in the tissue. And can you see that the decortication is a little about 1 to 2 millimeters medially. Now next what I do, it's an Iconics speed anchor, all suture anchor. I would place it just above my biceps groove. This is done through the anterolateral portal. Once I've done that, I intend to do a biceps SCR. There's no role of this salvaging this biceps, so I might as well use it as probably a restraint for my proximal migration. If you see the MRI, there was some amount of proximal migration. I have then used this. I do a simple biceps SCR. So here I am. Here is where I left my work. I will go back, just put on my gloves and start off my surgery. Give me a minute.
Okay, so you basically looped one limb of each suture around the biceps, right? No passing it through the tendon.
Yeah, Anshu, I can't hear you.
Hello? Yeah, can you hear me now? Yeah. No, so what I was asking is you have looped one limb of each suture around the tendon, not passed it through the tendon, correct?
Yeah, exactly.
Correct.
That's exactly what I've done.
Yeah.
It's a simpler way. I mean, rather than fiddling around too much, see the entire concept. Am I audible?
Yes, you are, yes.
Yeah, the entire concept is to give it a restraint against the proximal migration of the humeral head. So until unless I get that pressure effect, now this is a degenerated biceps tendon. Taking a bite through this biceps tendon is rubbish. I would just use that biceps tendon as a restraint to my proximal migration. However, I have decorticated the bone below that, so over the period of time, it would just tenodase to the bone. And I have had no problems at all. Just to make things simple, just to keep life easy. Any other way of doing this, Anshu?
No, of course, with such a degenerated tendon, you would not want to pass any sutures around it.
Yeah.
So you're viewing through the Grand Canyon portal now?
Yeah.
Okay.
I'm Grand Canyon, yes. So I'm viewing through the posterolateral portal.
Yeah.
I'm just putting on my gloves and my gown because I had to move to the audiovisual room to play the recap.
Okay, so and what's your plan now after having managed that biceps?
My plan is to repair this cuff.
No, of course. Otherwise, Teerth will kill you. How do you plan to repair that?
So I can here either use a double row repair or a single row repair.
Okay.
I have already put one anchor there and I don't see that bone stock is great. She is a little elderly lady.
Okay.
I would rather concentrate on the coverage of my footprint. Now since I have a restraint to my proximal migration, which will be taken care with my biceps, I just need to put these tissues back to place and hold it in place. So I will put a medial row anchor, do a parachute with the fiber tapes.
Okay.
Fiber tapes, you get it with Iconics speed from the Striker guys. So it's quite a handy all suture anchor. Okay, I'm back here.
Okay, now so we have one question from Dr. Rajkumar Amravati.
From whom?
Dr. Rajkumar. Dr. Amravati, sir.
Yes, sir.
Chirag, good afternoon. Nice exposition of the shoulder and the view that you are seeing here is very good.
That all thanks to Dr. Teerth and Dr. Pratmesh. They have given me a brand new arthroscopic set here.
Oh, great.
With the camera.
Okay. And since you have mentioned that the retraction of the cuff is almost till the glenoid.
Yeah.
And you have seen this ragged biceps and the subacromial area, which is not greatly looking after debridement. It is great.
Yes.
What intra-articular view that you have done to help your cuff repair better? Since you are planning a double row repair, probably it will require some amount of releases also.
Yeah.
What are your releases that you have done intra-articularly and also in this subacromial area?
So this is not a very scarred cuff, sir, for reasons unknown. Probably because she's from the village side. She's been doing her normal activities by herself. So she's not really exerted too much. Can you see that? I'm just tying my...
Yeah, we can see that.
Now when you do that, my assistant is just pulling the head down. Pull it down, Baba, Dhruv, so that my biceps is fixed and also the limb. Can I have the external picture, please, of the arm? Can I have the external picture of the arm?
So what's the location of this anchor? How posteriorized is your tendon now?
Not
from the groove?
much, not much. I will show it to you. I'll show it to me. Just capture the arm position. My forearm or my elbow is extended here. When I'm doing this, my elbow is extended. My assistant is giving a traction towards the floor so that the proximal migration is to some extent taken care of. Do you follow what I'm telling?
Yeah, we can see your external view now.
Yeah. So here I am. Hold this, please. Pull that. Yeah. Okay. Now free this. Excellent. Come on. Hold this. Hold this, please. Hold this. Yeah. What was Dr. Rajkumar, sir? So for your question, Rajkumar, sir, are you there?
Yeah, he's there. He's listening. He wants to understand what releases you're planning to do.
And I'm
Yeah.
watching
I will just
physically
show it in a
also,
bit. I didn't have to do much of a release. I have just released the medial portion. Pull it, Ray. A little bit. I have just cleared out the bursa, and that has helped me get a good.
If you have another chance to,
I will show that.
shift this biceps,
Yeah.
would you want to do some more releases on the intertubercular area for the biceps to settle more
See,
posteriorly?
Yeah.
As
So,
Anshu was asking?
that would be in a pristine pulley. If my pulley integrity was good. This is already subluxed and it is degenerated. Now what pulley will I release there?
No, if it is there, how far down you will go to release it and bring it down?
Only the proximal third.
Okay.
Just to allow that excursion of the biceps. Nothing above that.
Okay.
So I would just do a proximal third of the pulley release, nothing beyond that. So that was not required in this. It's quite a degenerated and subluxed biceps. So there's no question regarding arising with that. Here you are. My biceps SCR is completed.
So are you using a pump because your patient is in sitting position, right?
Yeah. No pump.
No pump.
Yeah.
Okay.
So
So
here
how
you
are
are.
you maintaining this kind of a
Now
field?
if I see this is, I'm giving a thrust from below. Leave it. I'm giving a thrust from below.
Right.
Can you see that? My head is not getting migrated proximally much. Okay, can you follow that? That's your glenoid. Now hold this. So usually when I have a look, when I encounter these stairs, what you anticipate is you anticipate kind of a, grabber please, eyes down. You anticipate a kind of a laminar tears, but thankfully this is not much laminated. It's a single tear here. There's no delamination there. And if you see that, this tendon is quite easily retractable to the
excursion.
footprint. Yeah, to the footprint, easily
Yeah.
retractable to the footprint. Probably I had to release a little bit of the bursa here, a little bit of a bursa here. I didn't have any scarring, so I have not gone below, and I just used my probe there, and I released this, below the cuff,
Right.
in the supraglenoid area.
Okay.
And all these anterior structures, I didn't really have to make an attempt of releasing all these ligaments there. So my plan would be to put now here, accommodating 2 anchors. Would somebody accommodate 2 anchors here?
Yes.
I will just put a central anchor, and that will give me, I will show you a trick. I'll
Okay.
just put a central anchor here, and I think that would be adequate for me. Tape please, tape anchor.
So what anchor are you planning to use? All suture again?
Yeah, all suture.
So you
I
said
mean,
the bone
ideally-
quality is not great.
Yeah,
Are you not
ideally
jittery about it?
what I would do, come on, give me this thing, punch. I mean, tap of that. Yeah. So if you see this, Anshu,
Yeah.
I will just keep this and see the bone quality. Okay,
Okay.
that is okay. Now this is bad.
Yeah.
This is okay. This is okay. So I usually do this test, and this is the place where I would place my anchor, where there will be a little bit of a purchase, and my anchor would be having less chances of pull out.
But this is quite far removed from the cartilage margin, is it not?
It is, but I will get my cuff, I'll take my bite 2 centimeters medially, isn't it? So when I take my bite in the cuff 2 centimeters medially, Do you get what I'm talking about?
I get it. So 16 millimeters is a footprint because you are
Yes.
here 5 centimeter lateral. You want to compensate
yes,
there.
Yes, exactly. So
Right.
simple. I'm not a big mathematician, but the simple what I understand is come on.
So is this your anchor of choice for cuff now? All suture anchors?
Most of the times this is quite a handy anchor because I get 2 tapes in this. That's the beauty of this anchor. Of course, if it pulls out, I'll use something else now.
In the osteoporotic bones also, this is the choice.
Metal anchors can be used, but metal anchors don't come with tapes. Look at that. I'm just pulling, giving a good thrust here. Good. Knife, please.
This is a double loaded, is it?
Yeah, double loaded anchor.
Okay.
Now double loaded with tapes. So tapes, I think tapes have a good purchase, and I've been happy with these. They've been helpful to me. So let me see. Come on, I'll have a 8 mm cannula, please. Hold this. Hold this. Hold this. 8 mm cannula. I'll just insert one more cannula.
Okay. And which portal are you going to put the cannula in?
Lateral.
Okay.
Did I tell you to remove that, Dhruv? Huh?
So Chirag sir, how do you maintain this kind of a field? It's a very clean field in a sitting position. You're not using a pump.
Yeah. There are 2 notorious fellows of mine.
Okay.
Shoulder got scared. Okay, that was a bad joke. Okay. so the anesthetist is very good. The BP is damn low, and I have pushed in half an ampule of adrenaline into them.
Each bottle of NS.
Yeah, half an ampule.
Okay.
Okay, that's all what I do. This pump business is little dicey. I really don't like it much,
Right.
and that's my not a very acceptable, because just hitching the acromion, I would just come on to there's not a great space there. That's what I had asked for the acromiohumeral distance to be measured, because that's one of the problems. You see this? The acromion is just there and the tuberosity is just there. So you hardly get some space to put your instruments here. I'll have to do acromioplasty if not, which I really don't want to do right now.
Okay.
Come on. Give me ice tongue, please. So here what I'll do is, what you guys can do is, I will start repairing the cuff from anterior to posterior. So what I'll do is, come on Madhuri, separate the white ones. Pull one white. Which you're pulling, leave, hold the other white. Okay? Done? Hold that. I'm just retrieving to the posterior portal.
Yeah, all right.
3 limbs. Why isn't this coming? Yeah. Now load that. I'll take a shoulder scorpion. Hold that, and then my superior bite. Now a small trick here, when I do this, I see if I've got enough tissue bite there. Yes, I have.
Okay.
This is my first bite anteriorly. Okay? Here
Okay.
we are. Ice tongue, please. And there goes my pato, no?
That's a shoulder scorpion you use, right?
Yeah. So can I have one more white thread?
So Chirag sir, why
yeah.
not use 2 anchors, have more number of sutures, because we know the greater is the number of sutures, the lesser is the strain per.
Yeah, Anshu.
Yeah.
You saw the bone quality here. Me struggling with 2 anchors, coalescing those two holes. We have all gone through that, isn't it?
Okay.
Do you think I'll get any purchase anywhere? Bone quality is good anywhere here? There's one anchor I've got, that is my start. So I would rather be on the safer side than get into all those issues, especially in a live surgery.
Chirag, Vishwadeep this side.
Yeah.
For this particular bite, would you want to take a bite through the biceps and then through the cuff after putting it in excursion?
No. I think that is a very bad idea to take especially if you're putting a lateral row anchor. It's a bad idea to take a biceps along with your supraspinatus, because you know what happens. The lateral anchor invariably pulls out. Because your biceps is not so free, and you are trying to put in a free structure, merge a free structure to a static structure, relatively static structure, and then when you're trying to pull your lateral row anchor, your supraspinatus is excruciating well and it's coming, whereas your biceps is more rigid. That's when your lateral anchor gets pulled out.
Yeah, so wherein if you have a cuff deficit repair, wherein you have your supraspinatus is not reaching up to the footprint, you could actually use this biceps to reinforce your, that's what point I wanted to tell.
That we can, definitely.
Yeah.
I would release my biceps fully, completely.
Yeah, in that case you would have to release right through the transverse groove, release your pulley.
And I will not anchor my...
and shift the biceps at least 10 mm behind.
Yes, and I will not anchor my biceps to the bone before that.
So in this bite, you did not want to see how your needle is penetrating?
I can. You see that? I know that it's 2 centimeters deep, and I know that there's no other structure there.
Okay.
Here you are. This is the top one. Hold the other one, please. Hold that. Yeah, come on. Now, I will take the last limb. Where's the last limb? Yeah, leave it to me. Hold that. This is a fantastic anchor. I'm fond of this iconic speed. It saves one step. These iconic speed anchors, I have become a fan of this, especially these tapes. Look at that. It doesn't cut through usually. I mean, in case if I anticipate a cut through, I'll just put a ripstop suture first. 1 or 2 of them, and then go ahead and do this. Now this is far through my infra. Can you see that? Anshu, are you happy now? I'm seeing that.
Yeah. So this is...
Hold that.
Okay.
Yeah, you had some comments, Anshu?
Yeah, I mean, personally, I would have wanted more number of sutures through such a large...
Yeah, I know. But looking at it, I've already put one here.
I get that, yeah.
And me struggling. Give me the probe, please. Give me the probe. I don't think even a metal anchor will stay with all this. Can you see the holes what I've made there? If I keep fiddling with that, I will try putting an anchor here. That becomes a dent. It gets merged. This anchor also will get pulled out. Then I try to accommodate one anchor here. Even that won't. Can you see my probe going inside?
Can you, Chirag, Vishwadeep, this
Look
side?
at this. Yeah.
Can you show us and can you shift your viewing port in the anterior most portal and show us the behind, if you could?
Yeah, I can.
If you can.
Your request
that might give you a different perspective.
Your request is my command, sir. No. That's the anteriormost portal. Let me just go in there.
There's an anterolateral portal now we are viewing through.
Yeah. This is the viewing is from the anterolateral portal, and here, since I have a cannula there, and that's my Wissinger rod. Wait. Here we are. Vishwadeep, sir?
Yeah.
Can you see that?
Yeah, so what point I wanted to make here is that if you can use your suture manipulator and try to pick up the ISP, then you could able to see if there is at all how well the ISP is getting reduced, and if that delamination tear on behind.
Can you see that? So this is a delamination. So I've taken both the wings here.
A little more behind. If you ask your assistant to internally rotate at this moment.
That one, yes.
Internally rotate. Put your light source a little bit more horizontal.
Got it.
So
that this part. One you're talking about.
But this part. It's important to take bites in this part.
That did pass through my mind. But you see this as I go towards the footprint. This has an attachment. this laminae has an attachment.
Yeah,
and
so
this laminae is attached to that.
yeah, so if it allows you, then probably you can
Yeah.
put an anchor here through the same probe which you are inserting.
We can,
Yeah,
we can.
it will get you an angle.
Yeah,
and
it will
then
get
you
me
can,
an angle,
yeah,
but the problem is, can you see that?
yeah,
Can you see that,
yeah,
Mr.
yeah,
Dipsar?
yeah.
If I
Yes,
put
you
in
are the
a-
best judge at
Yeah,
present.
if I put in an anchor here, there's no way any anchor will stay there.
Yeah, you can take your call.
I would do least and get away with a decent repair than doing something heroic and messing myself up. That is pulled. Huh? Okay. Now I will withdraw all these threads
Okay.
through this portal. Now where's my other blue? I'll have the other blue. Yeah. Okay. Now give me the whites, please. Give me one white.
Chirag, will you be using your double row anchor?
Yeah, of course. I'll use the lateral row anchor.
Yeah, so in a lateral row anchor, if you have a extra thread, or
Yeah,
if
yeah,
you
I can
use, so
yeah, I can use
instead of,
that. Yeah, I
so
can
you
use
can
that.
use that thread to hold off to the ISP part
Yes,
which
yes.
you
Come on,
just saw,
saline, guys.
and that way you will be able to take one bite without endangering.
Yes,
I mean,
yes.
the
I
soft.
can use that for
Yeah.
for that laminate
Yeah, do
there.
that. I think that will be helpful.
Yeah, so I will just see at this point, pulling all my threads, will that come back there? So I will be left with the dog gear, and that I will use that suture material or the,
Chirag,
yeah.
Subra here.
Who?
Subramanian.
Subramaniam sir.
Yes, sir.
KNS sir.
Chirag, I think bone quality is quite bad. I agree with that. So whatever anchor you are going to put, it's very difficult to hold it there. I think as Vishwadeep was already suggesting, I think, to take a free tape and
Yeah.
take a bite from the posterior
Yeah, I will do that, sir.
infraspinatus.
Yeah.
And you can use an additional lateral row anchor.
Yeah.
So you can use two lateral row anchors.
Yeah, so let me finish my primary work, see what is the void, how much of a...
otherwise, I think your fixation is coming pretty good. Yeah.
Yeah, so I will be about 1 centimeter below this
Yeah.
margin here. That's my intention. And I will not disturb this kind of a tissue which is holding that laminae. I do not want to debride that. I will probably see the best. We all know that the posterior lateral portion of the bone is the best bone to get your lateral row anchor about 1 centimeter below that edge there. Just going to put so let me just if I can get 1 minute here, so I will just tell the delegates what exactly I'll be doing.
Yeah.
So this is my medial row. Look at that, in spite of the force, there is no cheese wiring of the cuff here. So I will put a lateral row anchor somewhere. Give me a messenger rod, Budama, Budu. I will use a lateral row anchor somewhere over here. I'll see the bone quality first. This bone quality looks good. So my lateral row anchor will come in somewhere here. I am going to use a omega anchor here, which is quite a good anchor, and it's got a good hold. You can visualize as I'm doing that. Okay, my voice will be off, and that's what was supposed to be.
Yeah. Thank you.
Yeah, Chirag sir, you are on back live.
Huh?
Hello? Yeah, Chirag sir,
who's
yeah,
there?
you're back online.
Dr.
Yeah.
Vishwadev, Dr. Anshu?
Yes, yes, we can hear you. Yeah.
Dr. Vishwadev, Dr. Anshu, can I, somebody?
Hello,
Somebody on the
Alpha,
other side?
Beta, Tango, cameraman, audio.
So, Chirag, you are live.
Huh?
Can you hear us?
Can somebody hear me? Can somebody hear me?
Yeah, light is traveling, sound has not. Light travels faster, no? Yeah, come on, yeah.
Yeah, can you hear me now, Anshu?
Yeah, we can see you now, yes.
Okay, here we are. This is my kind of a parachute repair what I've done. So you can see that, extend rotate Baba. So that is the biceps SCR which is holding there below that, and that's my anterior most suture limb.
Sir, can you shift your scope to the lateral portal? We will get a better view.
I will do that. So
Yeah.
this will give me a
Also,
better
Chirag,
access.
have
Yeah.
you released the biceps distally?
No, I have not. I just reroute that because see, I can do that, but I don't feel.
But
a
yeah,
need for
because
that.
the intra-articular portion of the biceps,
Yes.
if you noticed, na, it was in a bad
yes,
shape.
Yes, it was.
So
it was a
patient
bad,
might get benefit with the release.
Yeah, I may do that, but it will anyway. It will go into auto. By what do you call it? Tenotomy. Yeah, it will go into auto tenotomy because I put it tight there. It's rerouted. Of course, there's no pulley, but I think it will naturally. It will go into auto tenotomy. That's not a problem. I can do that if you wish to, but I'll. Yeah. So this is through my lateral portal, true lateral portal. Now here you are. That's the antermost portion.
Right.
And that's the, yeah, so that's my footprint. I mean, look at that footprint, almost good coverage, and I have good approximation. I've got more than 16 mm
Right.
of my footprint cover, and I've medialized my bone rasping, so I get more bleeding there. So I think it should tenodize over the period of time. So this, let me just abduct and adduct. So I always check my tension of my repair with abduction and adduction.
Okay.
If I can do that through 1 second, if I'm not taking too much of my time, yeah. So this is adducted position now. And since I've done my lateral row in 30 degrees of abduction,
Yeah.
I also need to see in my adduction, complete adduction,
Yeah.
is my cuff under tension. Second thing what I always look for, go back and see your musculotendinous junction here. So most of the times, if the tension is too high, there's a chances that the musculotendinous junction can get ripped off.
Okay.
So I also have a look at that. That seems to be okay. That seems to be okay here. That seems to be okay. I'm fine with that. My integrity of my cuff is fine. I also run through a forward flexion range. I run through the backward flexion range, abduction of about 90 degrees to see if there's any kind of impingement of these dog ears. Dealing with this simple small dog ears is nonsense, I feel. I don't need to do anything about it. It will flatten over the period of time. And here you are. This is how I rest. Now, without giving a traction, I still can seep in my scope, which I was not able to initially. That means my biceps SCR is working. So this is about more than 8 millimeters to 1 centimeter of acromio-humeral distance, which I'm happy. The lateral margin of my acromion is not pinching into my cuff repair as I'm abducting and as I'm forwardly flexing. So no impingement. I'm good with this, so I will sign off from my surgery, and I would thank the entire team of the first Ahmedabad Arthroscopy course, especially my dear friend Dr. Prathamesh and Tirth for putting up this wonderful show. Hope your program continues year on year, and hope it sees tremendous success in years to come.
Okay,
Thank you.
Chirag sir, before you go, one last question.
Yeah.
What do you bet will work more here, the depressant effect of the biceps or probable healing of this cuff?
Dual effect. So I will mobilize her. I will put her on a muscle stimulation right away with probably a Faradic or galvanic on the supraspinatus and infraspinatus. Tell my physio to do that. I will start her shoulder scuff, scapular retractions and isometric exercises of the cuff straight away, since it's a stable repair. I will then ask them to recruit my supra and infra as much as possible within 3 weeks' time. Start her on active assisted range of movement in about a month's time, and get her onto an active range of movement in about 8 weeks post surgery. I know it's a little bit of a
it's very aggressive,
rapid protocol, but I need to do that. If not, this 50% fatty degeneration will turn out to be 70%.
All right, sir.
Yeah. SCR will protect it. That's all.
Okay. Thank you. Thank you
you.
so much. A
Thanks.
great demo.
Thanks.
Thank you.